Hello everyone, and welcome to today's webinar, Sepsis and Septic Shock, the Paradigm Shift to Ultrasound in Patient Assessment. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You have joined the presentation using your computer speaker system by default for audio. If you prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. The audio pane is in the control panel to the right of your screen. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of the presentation. Today's webinar is being recorded and you'll receive a follow-up email with a link to view the recording. I would now like to introduce Jonathan Bowman. Jonathan?
Hello. Welcome to the second webinar in a series of lectures pertaining to the condition of medical shock, sponsored by GE Healthcare. We are glad to have you all join us today. Again, my name is Jonathan Bowman, and I am the Education Leader for Point of Care Ultrasound at GE Healthcare. Today, I will be the moderator for our webinar with Tom Ahrens, PhD, RN, and faculty member of the American Association of Nursing. Tom will be presenting today on sepsis and septic shock and how ultrasound may aid in patient assessment. There will be several polls that will populate on your screen before the presentation. If you will, please take a second and respond to these polls. We also ask that you post your questions to the comment box located on your computer screen, and at the end of the session, we will answer the questions that have been posted. In case you'd like to access today's presentation in the future, please know that we'll be recording the session and a link to the webinar will be delivered in an email to you in the next few days. Without further delay, I'd now like to introduce you to our featured presenter, Tom Ahrens. Tom is a research scientist at Barnes-Jewish Hospital. He is actively involved in sepsis education and technology application, particularly in terms of hemodynamic monitoring and capnography. His book, Essentials of Oxygenation, was an AJN Book of the Year. In 2004, he was inducted into the American Academy of Nursing. From 2006 until 2008, he was an AACN's representative to the Surviving Sepsis campaign. And since 2009, he has been an AACN's representative for the Critical Care Society's collaborative with a goal to establish a research agenda for critical care in the U.S. It is now my extreme pleasure to welcome Tom Ahrens.
Thanks, Jonathan. I think our polls are still being delivered, and we're getting some answers here. Let me watch the polls be finished, and that gives me a little baseline of who's attending. And I think we're on our third question now, what parameters specifically being changed when given a fluid bolus? And okay, that's perfect. So we're going to go ahead and start. I just want to start by going over, I have no conflicts of interest. So for this lecture, everything I'm telling you is trying to be based on what the science is. This also is not a lecture on how to do ultrasounds. This is a presentation that's really designed to say, how do we use ultrasounds in assessment of patients? Now, the first slide you look at is a little ironic, because what I have on here is a stethoscope. Give a story to kind of introduce the talk. Several years ago, I was given a lecture for the European Society of Intensive Care Medicine, and the topic I was on was advances in hemodynamics, which is one of my areas of expertise. And at the time, I'd said that our practices such as measuring pressures and using techniques like a pulmonary artery catheter were basically obsolete for most patients. And one of the clinicians who was attending said it was about time we quit using old techniques like the Swan, since we had newer and better techniques. And I said, you're absolutely right. I said, but we don't change easily. For example, the comment the clinician made is that The Swan-Ganz catheter, for example, is at least 50 years old. And I said, I agree with that. If you would look at technology that's over 50 years old, should we quit using it? And of course, the example that I would give is a stethoscope, which is 200 years old. And so our question is a stethoscope obsolete? Well, for most purposes, it probably is. There's some things that we can still use a stethoscope for, but for the most part, we're better than that. We've advanced enough that we can do more than just try and hear something and then infer a clinical situation by listening. And I was very pleased with the first poll question that showed most of you, over half, are using ultrasound as part of your regular practice. That's wonderful. This will be very easy to incorporate into this presentation. The one thing that was a little interesting is when you look at the poll question that said, if you give a fluid bolus, what are we trying to change? There's only one thing we're directly trying to change when we give a fluid bolus. And all of you, if you think about it, you know your physiology, you know this answer. The only thing we're trying to change is how much blood the heart's pumping. In other words, stroke volume. And if stroke volume improves enough, we should improve cardiac output. But when you look at things like changing our practice to measure stroke volume when we give a fluid bolus, the research on that, as I'll show you, is very, very strong. But we still see clinicians not using that parameter. Now, there's a couple reasons for that, but also it gets back into this quote that I showed from Thomas Kuhn. And some of you may have read Kuhn's book, The Structure of Scientific Revolutions. But he talks about how we work within a set of rules, or basically a paradigm, that governs our behaviors. So, for example, if you believe that blood pressure is a good endpoint, then that's going to guide your treatment decisions and your assessment decisions. If you believe blood pressure is a late indicator and is not likely to warn you of a patient's deterioration, then you're going to look for other rules to follow. And as you look at this presentation today, really the goal is to say, where should we be in terms of using parameters and techniques like ultrasound? And it becomes pretty clear that ultrasound should be used really routinely, and not only because of its accuracy, but because of its speed. And we get clear answers rather than trying to guess what's occurring. So the first few slides I'm going to go through just goes over some basics in terms of a paradigm. What paradigm do we work in? And this really, you ask yourself this. When you look at a patient, can you tell how they're doing? You see in the answer to this, I said, no, we can't. And the reason for that is because of the research studies that we've seen, and you've probably seen it from your own personal experience, is people can look normal, patients can look normal, maintain blood pressures that are normal, even though they are having significant change. I'll share a story in a little bit about one of the salespeople who actually sells ultrasound, had a ruptured ovarian cyst, had lost over 2 liters of blood, and she was still talking to me. Just said she didn't feel well. The point being is, if I had a better monitor on her, now again, this was a friend talking to a friend, the key thing is that we would have known that she was in danger and had to go to the OR quickly. So here's a problem that we look at with sepsis, and many of you are very familiar with this, is that sepsis is not a single entity. It'll present in different ways. And when you look at the SIRS criteria, those of you who have been around for a while know that when Roger Bone proposed the SIRS criteria, systemic inflammatory response syndrome, he also said we need to keep in mind about CARS and MARS, the counter anti-inflammatory response syndrome and the mixed anti-inflammatory response syndrome. When what he was basically saying is that we're going to need different treatments for sepsis depending on the stage that the person's in. And I think this is what many people have, many clinicians have questions about regarding the protocol from the Surviving Sepsis campaign, where when we say that we should give 30 milliliters per kilo to a person who has sepsis or severe sepsis by the older definition, the idea is that the goal was so we didn't underperfuse people and so that we'd give them adequate fluid. But no one really would believe that giving 30 mils per kilo is right for everybody. And ultrasound makes that crystal clear when you see patients. So, for example, this gentleman went through several stages of sepsis. He had come in from a motor vehicle accident where he had actually fallen out of a car on a highway and developed sepsis about 4 days into his hospitalization stage. Now, the point being is that how we treat him would have varied depending on the state. And that's one of the things we'll go through as we look through this. Say that this is a young man who comes in with an abscess on his leg, and a question for you is he in any danger? Well, he's got a wound, so he has an infection. Does he show signs of SIRS? He actually had one of the classic signs that showed he was in danger is he had mental status changes. And so now luckily, the emergency room recognizes quickly. Ultrasound of his heart showed he really didn't need fluids, and rapid antibiotics was all he received. There was his wound packing, and here's his wound just like 36 hours later. The point being is that he recovered very quickly, and we didn't even give him fluids. Now, that would have been a violation of the Surviving Sepsis Campaign guidelines and CMS. But the ultrasound showed that his fluid status was adequate. And that's the problem with going with a protocol, is how do you know what each individual patient needs? The protocols are designed really to protect against a gross mismanagement, for example, that people just consistently under-resuscitated. But the 30 mils per kilo can't work for everybody. It's really not intended to. What stage a person's in? Are they in the early hypovolemic phase? Are they in the hyperdynamic phase of sepsis? Again, I'll give an example. One of our pulmonary and critical care fellows asked me to look at a patient in our surgical ICU who had been diagnosed with a surgical wound infection and had sepsis. So we go to see the patient. They're given fluids to him, and the question I asked the resident is, how much fluids have you given so far? And he says they've given 10 liters, which is enormous volume. I said, why are you given that much? He says, well, the CVP is still 2, and it had started off at 2 and hadn't changed. So the problem with that is the resident wasn't intensely doing anything wrong, but he was using a parameter that wasn't very accurate. When I measured his stroke volume and cardiac output with an ultrasound, his cardiac output was almost 18 liters. Stroke volume was 160. He had plenty of fluid being delivered. Now, he probably had very poor microcirculation, and that's a different story. But the point is when we give fluid to someone, we're really trying to establish a macrocirculation improvement, and all we had to do on this patient was measure stroke volume, and we probably would have realized we did not need to give that much fluid. The point, what we're trying to do when we give fluid by measuring blood flow parameters, stroke volume, looking at ultrasound of the heart to see if the heart's contracting properly and is there adequate fluid in the ventricular chambers. Our whole goal is to avoid a called hypoperfusion. And that's really the goal of the Surviving Sepsis Campaign, of giving 30 mils per kilo. Too often what we've seen in the past is under-resuscitation, where patients will still look okay from a vital sign point of view, but they're being under-perfused in terms of their organs. And so what this illustration shows is we're just measuring cardiac output and stroke volume with a non-invasive technique. Now this is a flow Doppler, not an image Doppler. So what it really just measures is flow. Now you do get an image that you can get with a regular ultrasound as well, but it's designed to be a simpler, easier way to move. But again, all of you who are clinicians who've looked at septic patients, this is information that you know will happen. Gets back to Roger Bone's statement on how sepsis occurs in phases. And so the blood pressure and heart rate of this patient, blood pressure borderline, a little low, heart rate's up a little bit. Stroke volume, which normally 50 to 100 is clearly low. Cardiac output is close to normal or normal, but it's probably because of the tachycardia. You could look at another parameter, how much oxygen extraction is taking place. And this person here, they've got increased oxygen extraction, which would be a sign of distress. But this would only be available if you had a central catheter in place. Now, the stroke volume of 44 is interesting, though, because that's what will respond to fluid. If you notice the patient's heart isn't pumping enough blood, which you would note with a stroke volume, you'd be able to easily see this person needs fluids. Same patient a little bit later, though, in their clinical course, notice that their heart rate is still up, blood pressure still about the same, but look at the change in stroke volume. We did nothing different. We had given them fluid already, so we weren't actively treating them, but then the stroke volume changed. The patient literally morphed in front of us. And all of you who take care of patients and do continuous monitoring, or just do regular ultrasound monitoring, you'll see this. You'll see the heart go into a hyperdynamic phase. Now, the interesting thing is you look at the venous oxyhemoglobin. Now, it isn't low anymore. It's high. And what that's showing is either cell stunning is taking place, we have microcapillary obstruction taking place, something is going on that's preventing oxygen from being utilized at the tissue level. The point of this, though, is does this person need fluid at this stage? And you could argue no. He's got plenty of fluid. But this is the same type of patient you'll see in the emergency room, in the intensive care units, on a rapid response call in the hospital. And our goal is to try and make sure this person isn't underperfused. Well, he's perfusing macrocirculation very well. You could argue he's not perfusing microcirculatory. And so this slide just gives an example of what I'm talking about. When you look at the scenario here in sepsis, you'll notice that, again, remember the pathophysiology is that what we'll have is microcapillary obstruction, which is normally a good thing because it helps isolate an invader, whether it's bacteria or virus, from spreading. But for some reason, in patients who get a systemic response with sepsis, we get microcapillary obstruction occurring in many places. And at this point, blood flow can't get into the tissues. So the question comes up is, let's give this person more fluid. And what will an increased fluid bolus do to the microcirculation? And the answer is probably not much. It'll push on those obstructions, but it won't be able to get rid of them. The same thing would apply when you give a vasopressor. You can increase the blood pressure, but have you really helped improve perfusion? It's one thing that's not part of this lecture or this presentation, and we certainly could do another one where it gets at tissue oxygenation measures. Many times we can make an improvement in parameters such as arterial blood pressure, but not really improve tissue oxygenation. So we're stuck at this point, though. We have very few effective treatments. Matter of fact, we have none that really have been accepted by any national bodies. So this means if we see a patient at this level, we're really struggling just to keep the person alive. But one of the things about a paradigm shift is that when you look at our current tools that we use, we still are very tied into using a surrogate for flow, and the most common one we use is pressure. While the literature has been pretty clear that pressures like CVP don't really correlate to volume, and certainly not to flow, we still rely heavily on blood pressure. Matter of fact, many ICUs like blood pressure so much that we measure two of them. We measure arterial lines and cuff pressures, and then argue over which one we're supposed to use. But the important thing is that the blood pressure is not going to be an early indicator of flow, and we've known that for over 70 years. Remember, your basic physiology will tell us that. Is that when you look at the first parameter that changes in terms of a person needing fluid, it's stroke volume. Everything else is compensatory. So, for example, if the stroke volume doesn't change, there's no reason to develop a tachycardia, there's no reason to lose perfusion in any organs, and we wouldn't see the clinical signs that would be associated with shock. What starts the problem, though, is the change in how much blood the heart's pumping, stroke volume. So that's really our centerpiece. That's what we should be focusing on in terms of making sure that we've normalized stroke volume. And that's what the research literature basically has been showing us. We know the blood pressure is not an early indicator, it's late, so you could argue, why are we measuring pressures at all? And that's a whole separate presentation. But the goal is to move toward measuring flow. And the best way to measure flow is going to be with ultrasound. When I talk about the use of ultrasound, and this particular slide talks about an esophageal Doppler, but the evidence to use flow to change patient outcomes is enormous. And the idea being is that it follows a very simple physiological point, is I should be able to improve stroke volume whenever I give any type of fluid, and by doing that I'll know exactly how much to give. So for example, this is a patient, not a septic patient, this is a patient that we've used prior to going into surgery. But notice the stroke volume is 77, and that's actually normal. You can see that the arterial waveform looks good, so we've got a good position, and this person looks pretty good. Now, does he need any fluid? Well, you also could look at a parameter such as flow time, and the flow time is just borderline low. And so here's the point, is if you think somebody needs fluids, give them some fluids and see if they get a response, see if their stroke volume increases. And this particular patient gave fluid bolus, and notice the stroke volume went up to 91. The whole point of this is a flow ultrasound that is used. It's available. It takes just a very short time to put in. Next slide, I'll try and show you. This is one of our advanced practice nurses and sliding in an ultrasound Doppler in one of our intensive care unit patients. Anybody can do this. Very easy to do. It's like putting in an NG tube. The only downside is the person generally needs to be sedated or with a decreased level of consciousness, because it's like a very stiff NG tube. So we can't always put in esophageal Doppler monitors. Now, if you can, though, the way you use it is very, very easy. Give whatever fluid amount you want, half a liter of normal saline, that's fine. If you do not see an increase in stroke volume of more than 10%, then you're done. You don't have to give any more fluid. But if you do see an increase of more than 10%, then you need to continue to give another fluid bolus. The point is, we will continue to do this until you see a stabilization of the stroke volume. This is the advantage of ultrasound. You're going to see it also when we go over image ultrasounds, is that you can tell immediately if your patient need any fluid, and if basically you can stop. Let me show you an example of another type of ultrasound. This is very easy to use. This is again Lynn, and Lynn is going to measure one of our advanced practice nurses' cardiac output and stroke volume in our office. Let me just show you real quick how this works.
Now it's there, yeah, I won't put it on. Hi Karen, I'm going to measure your cardiac output. Okay. And I'm just going to put this probe and put it above the bone here on your neck. And it measures your cardiac output. You can hear the sound.
So when you look at that, you can see how quickly we can measure someone's stroke volume and cardiac output. That technique it takes a little practice. If a person's intubated, you don't go to the suprasternal notch. What you're going to do is go to the pulmonary artery. But the point being is to show you how easy that is to do. And the idea being is that the flow ultrasound is available to all of us. We can use it on patients in the emergency room. We can use it in the ICU. We can use it pretty much everywhere. Now, the other thing that's really nice is now we have point-of-care ultrasound. So this example of actually one of our sonographers is measuring an athlete and looking at his the image of his heart. And so this is where we start to see another very useful advantage of ultrasound in sepsis. Because if you think a patient needs fluid or not, what you're going to be able to do is just very quickly look at the heart and see if it has any issues in terms of volume depletion. So I'm going to show you a normal example, then I'm going to walk you through this. So what you look at in this heart here is you can see that, first of all, if you're used to ultrasounds of the heart, this is easy to interpret. If you're not, I'm going to walk you through it. This is a normal heart. And what we'll do is, if I pause this here and go back to the beginning, as I walk you through what this is doing, you can see right now the mitral valve is closed. So here's the left atrium, left ventricle, left ventricular outflow tract. There's the right ventricle. Interventricular septum's here. Here's a posterior wall. So as you watch this, let's see how the heart acts during this period. And so right now we're walking through and you're going to see the mitral valve open. And right there, the fluid now coming from the left atrium and the left ventricle. You're going to see the left ventricle contract and exit earlier. And so as we look at this, nice contraction from the posterior wall and the interventricular septum. The left ventricular chamber is full. So this person does not have any evidence of hypovolemia. That would be what we'd see normally. And so as you start to get used to looking at the ultrasound image of the left ventricle, you can tell very quickly, let me go back and sample, does a person have any evidence of hypovolemia? So I'll walk you through this one again. So as you take a look at this, tell me, do you think this looks like the heart is contracting well? Right there you can see both the posterior wall and the septum are contracting. And the mitral valve is now open, and actually the anterior wall is actually touched, the leaflet of the mitral valve is touching the interventricular septum, which is a good sign. Shows contractility is good. And now we have blow out the ventricular outflow tract. So this is a very simple thing to do. You can usually get this reading within a minute, very fast. And you can do the reading yourself, or for example, you can have a sonographer there to help you. We even have our nurses being able to do that. You can put on color flow to actually look for murmurs. You can, now the angle I was showing you was a long axis parasternal view. This is a short axis parasternal view. As you use this one, it can show you the same thing in terms of contractility. So this is a very good contractile view of the long axis or the short axis parasternal view. You can also do measurements. Again, this is available with handheld devices as well as using a full echo machine. And I want to show you an example. You can find these very readily, even on something like YouTube. I just want to show you an example. Dr. Hensley and Dr. Noble at Mass General have a very good demonstration of use of ultrasound in sepsis. And what they show here, I'm going to show you an example. They give you an example of both a slightly decreased contractility, a significantly decreased contractility, and then I want to show you a hyperdynamic phase. And it just shows the different phases that sepsis will go through. So if you look at this, again, you can see they're pointing out you have a septum that's not moving very well. The posterior wall is, and notice that the mitral valve, the anterior leaflet, is not really touching the interventricular septum. So we move that ahead and show a more, this is the short axis parasternal view, showing the contractility is reduced. But take a look at a severely decreased contractility state. This is very important to keep in mind because this is the type of patient that you're going to see. Is this person have heart failure and sepsis? Do they have myocardial depression secondary to sepsis? We need to know what they have because how much fluid a person would need is going to vary depending on what that situation is. And there's a paper that they referred to. It's actually well referenced in the literature. It talks about the accuracy of looking for a hyperdynamic state in people that come in with sepsis. Patients with hyperdynamic states as they enter the emergency room are highly likely to have sepsis. So let me scoot ahead and show you an example of what a hyperdynamic state looks like. Take a look at this and where you'll see both the septal and posterior wall are touching each other. They're squeezing each other. Now, is that they basically have a close to 100% ejection fraction. The question is, does this person need fluid or not? This is one limitation of the image echo that I want you to be aware of. If you're uncertain, does this person need fluid or not, give them a fluid bolus and see what happens. If possible, have a stroke volume measurement, like with an esophageal Doppler, and you'll be able to tell right away if the stroke volume is actually increasing or not. So what you're able to get with this type of imaging is crystal clear information in terms of what is the patient actually have. What is their situation? Do they need fluid? Do they not? You can literally tell immediately as soon as you have your Doppler in place. That is so important instead of trying to rely on parameters such as physical assessment. When you look at the Surviving Sepsis campaign, remember that what they're trying to do is raise the bar for almost a lowest common denominator so people aren't missed. Those of you who are experts, in especially the use of ultrasound, you know those have to be customized based on the patient. And what you're able to do with the ultrasound is see immediately, does this person need fluid? Not 30 mils per kilo. How much do they need? How do you know when to stop? Some patients might be good with a half liter. Some might be needing 3 or 4 liters. You can't tell that easily if you don't have an ultrasound device. Now, there are other techniques for measuring stroke volume and cardiac output, but in terms of the accuracy, the literature is pretty clear that ultrasound is going to be your best technique. Again, there's a whole bunch of other illustrations that we can use, and I'm just going to show you this one here. If you take a look at this, notice the interventricular septum is large, and so is the posterior wall. And this could be just like young person, strong heart, good musculature, but it could also mean they might have a condition like hypertrophic obstructive cardiomyopathy. But the important thing is you can't tell almost any of that unless you're measuring. Now, there are other techniques to look at, and I'm not going to spend much time with this. We're going to actually stop the presentation here in a few minutes. But the idea is that you can look at the inferior vena cava. You can look at its collapsibility. The idea being is if during spontaneous inspiration you will see the IVC change, like here's a view where it's a normal opening. This is a good view of an IVC, and then on inspiration, notice it collapses. That could be an indication of hypovolemia. I've not found this to be as valuable as just looking, doing a long axis or short axis peristernal view of the heart, and if I see that there's a problem in that, in terms of is there enough volume in the heart, is then to use another ultrasound, but this time a flow ultrasound. Now, keep in mind that you can estimate stroke volume and cardiac output from image ultrasounds, but I've not seen that as to the point where I feel it's as easy to use yet. And that's really the whole reason why you'd like to go to a flow ultrasound if you have any questions on how much volume to give. So the whole point is, in this presentation, the goal is trying to make you aware, if you aren't already, of how easy and how important it is to do ultrasound measurements. The information that I've given you is not new. It's in the literature. For example, the YouTube video that I showed you, there's many of those out. The question I think that we have to ask is, how long are we going to be using practices that are not based on good science? Who's being harmed by that? Well, the people who are being harmed by that are potentially our patients. And so that's the reason we want to go to the use of more sophisticated techniques like an ultrasound, and we need to try and do that as quickly as we can. Just real briefly, the last thing is, if I would go to an administrator and ask for an ultrasound, you know, the first question you're going to be asked is, how much does it cost? These devices don't have to be expensive. For example, the handheld ultrasound that I use, that one costs about $8,000 to $9,000, but we can use that throughout the entire unit. When you look at the non-invasive flow ultrasound, I think that has a list price of about $30,000. But again, there's no reusables. It lasts for years. So it's not an expensive piece of equipment over time. Then the esophageal Doppler, I believe, it depends on the list price. It'll vary, but I'm assuming it's about $300 per patient. But if we can improve measurement of how much fluid we give people, the research studies have consistently showed that it can reduce length of stay, and we can see improvement in patient outcomes. And those devices aren't expensive at all. They actually become very cost effective. So at this point, Jonathan, I'm going to stop and see if we have any questions that I can answer before we stop the webinar.
Sure. Thank you, Tom. Again, thank you for your informative lecture. And like Tom said, we will now open up the question and answer portion of our call. Please remember, if you have any questions that you would like to ask, please post them in the question box in the bottom right-hand portion of your screen. So now, with that being said, I will read a few of the questions that we have already posted. Tom, the first one is, why is ultrasound better than other methods of assessing volume responsiveness?
You know, that's really the central part of the presentation. Is it is fast and it's accurate. It does not require much time to learn. For example, if you just focus on learning a long axis and short axis parasternal view, you can master that in a day. Now there's always nuances and you're always learning, but you can get the basics of it done pretty quickly. Now, we haven't even gone over the whole bunch of other applications of ultrasound. You know, this is really just asking about fluid. So the answer really gets into, it is fast and it's accurate. And it's going to be really superior to any physical assessment method that you use.
Perfect. All right, Tom, I have another question. What are the strengths and limitations of ultrasound as a volume responsiveness technique?
You know, and again, I don't think I'm being biased. We're trying to just go with what the science says. The only limitation I would give two, you have to have the equipment. And so you have to be able to convince your administration to get the equipment for you. The other one is, and it's not really bad, it's what happens with any new technology, is that there's a learning curve. And once you've mastered that, it's very quick. But for example, one of my books is on hemodynamic waveform analysis. And this is when we did a lot of PA catheters. And if those of you who are listening used to use PA catheters, you know the learning curve for that was very extensive. Ultrasound really isn't as bad. You could argue that it's easier than trying to learn heart sounds. So the limitation really would be there's a learning curve and there's a cost to it. But boy, the advantages, for example, I can't ethically give a fluid bolus to a patient without measuring either with ultrasound or stroke volume. I feel that that would be being unethical to patients, because I know I can be better than just trying to guess what's happening. And it's better than looking at blood pressure. The blood pressure will be normal really just before the person crashes many times, where the ultrasound would have told me that way ahead of time. So it's really hard to say there's significant limitations to an ultrasound. And again, you can learn how to use the technique yourself. You can have a sonographer, or some facilities are even training nurses now how to use it. So it's what the key thing is you act on the information. And if you do that, you're going to find you're able to resuscitate people quicker and more precisely. And that's really the goal.
Perfect. I have another question for you. What is the data that you could mention about flow ultrasound in pediatric patients?
You know, pediatrics is a great example. My area is not in pediatrics. I've done ultrasound placement in pediatrics, but I would assume that, and I'm not familiar with the data, so I apologize. And we can perhaps get some more data for the participants and put that online. But the idea is that the principles would still be the same. The numbers would be different, of course, but the idea is that you could still look at a heart with an image ultrasound and say, is the heart, or the posterior wall and the septum touching each other, indicating maybe hypovolemia? Is there poor contractility? You can still see those things on anybody, regardless of age. Now, there could be some nuances that I'm not familiar with, and again, I apologize for that.
Sure. All right, Tom, I'm going to move on to the next question. One of our viewers asked that it's not clear to them how to measure stroke volume with standard point-of-care ultrasound. In a peristernal long axis, where are you focusing the Doppler?
Oh, it's a great question. You really can't measure stroke volume at that point. Now, I'm going to put a caveat with that. I think some companies, including GE, are coming up with a better way of actually giving a clinician that information specifically. But right now, you can't measure stroke volume easily with a point-of-care ultrasound. You can estimate it. You can estimate it from the waveform. You can certainly tell as if your fluid bolus is working or not. And for example, an apical view of the heart would be able to give you a waveform that's a little bit easier to interpret. But still, there's not a number yet that I can use like I could with the other two types of ultrasounds that I showed. The ultrasounds that are designed to measure flow, whether it's an esophageal Doppler or the suprasternal notch type Doppler, those give me numbers, and it makes it a lot easier to make an interpretation. And I think that's probably the best answer I could give.
All right, I want to tag on to that a little bit. I have another question, kind of in that same caveat. Would you be able to say a little bit about when you measure the VTI in the left ventricular outflow tract and how the VTI on a carotid ultrasound would benefit using ultrasound?
Well, the key thing is you're trying to look at, in that case, of is the heart, is the contractility of the heart adequate? Are we able to see changes as you give fluid? I think that the specifics in our practice, what we do is not look at the VTI as much. What we do is if we see a change, if it looks like on a quick image of the heart, we see that on the long axis and short axis views of the heart, that it looks like a person has hypovolemia or a contractility issue, we put in an esophageal Doppler. The reason for that is then that becomes a continuous reading. And I probably should go back one or two questions back. The current limitation, obviously, of the point-of-care ultrasounds is they're not continuous. And the esophageal Doppler is continuous. So I don't know if that answers your question, but really when we look at fluid, we don't look as much at the VTI and certainly not in the carotid either. We look specifically at the left ventricle. Now, the esophageal Doppler, for example, measures flow down the descending aorta. So we're looking at blood flow right out of the left ventricle. Now, it does not count the flow that goes caudally to the head, but we're able to get a good correlation with overall flow.
Perfect. Have another question for you, Tom. Do you think there is a role for continuous cardiac Doppler monitoring in sepsis management and resuscitation?
Absolutely. That's a great question. I think it is absolutely necessary to try and watch what happens to your fluid. And again, many of you who are participating today know this. When I give a fluid bolus, I can see the results happening as I give the fluid. There's no reason to be waiting a long period of time. We should be able to optimize the patient really almost within 10 to 20 minutes. We'll see if we've given the person enough fluid. The idea being is we have to wait a while to see what's happening isn't true. We can, with a continuous measurement, we can see very quickly, did we optimize the stroke volume? And if we did, then we might leave the ultrasound in place for a little longer to make sure it doesn't change, because it can. But we can get that initial stabilization done very quickly. That's probably one of the best strengths of the ultrasound. Otherwise, you have to do, and you can also just do repeated measures, absolutely. So if you're not using a flow ultrasound, if you use an image one, you can just do repeated measures. But yeah, the more anything's continuous is the better.
Perfect. So I have another question from one of our viewers, and they say, in their emergency room, their approach to a patient with sepsis is focusing on the IVC, heart contraction, and lung. What is your reflection on this?
You know what? I think that approach can work, especially if you're skilled at obtaining those images. And so if you feel that's working well for you, I'd absolutely continue it. One of the reasons why I like to get a quick ultrasound view of the heart, because that tells me, do I need to really probably do something, start to do continuous measurements? And is it worth my time to go ahead and put an esophageal Doppler in, for example? The reason I like that is it's simple, and I can have any clinician do that to get the IVC as well as the long axis, short axis, parasternal view, and other views of the heart or lungs. Just takes a little more practice, and there's nothing wrong with that. It just, if I have a large staff, which we do, it's easier to keep it as simple as possible. So I hope that helps.
Okay.
Some of you who are very good with ultrasound don't need much more. You're probably very good the way you are. But if you're not and you need more help, that's why we like the other types of ultrasound.
Yep. And to kind of add, there's a second portion to this question. Is this approach, in your opinion, potentially accurate enough?
Oh, absolutely. You know, the one area that we have a problem, so just give a little background. On the Surviving Sepsis campaign, when I was there, and I'm assuming it's the same, they try and do everything they can to make sure that the recommendations they make are based on science. And it's a very admirable trait. But the problem is there's a lot of potential benefits that haven't had large randomized trials yet, and so they don't come up. And I'll use an example. When you look at the esophageal Doppler literature, which is extensive, I think there's over a dozen randomized controlled trials that show they work, but they've been mostly in surgical patients and some medical patients, and they haven't targeted specifically septic patients. So from a Surviving Sepsis campaign point of view, we might not even look at that because it wasn't done in just septic patients. Now, there's a good thing about that, but there's also a limitation. It restricts your ability to use assessment techniques that might be superior. And from the literature, and again, I'll use the esophageal Doppler literature, it has been shown to be so accurate that it improves patient outcomes. And all we're doing is improving stroke volume. So there's nothing really complicated or magic about it. And so the principle when we get fluid and sepsis is the same thing. We're just trying to establish macrocirculation. So I hope that helps answer that question.
Yeah, absolutely. We're reaching the top of the hour, and I want to try to get to maybe one more question. So this is from one of our viewers. What about the NICOM in looking at stroke volume versus, or in addition to the use of ultrasound? NICOM is a lot more user-friendly and decreases user variation of results.
Absolutely. It is extremely user-friendly. It's almost seductively user-friendly. So the only reason that I wouldn't encourage its use as much as I would ultrasound is that the science behind how it measures flow is not as strong as what we see with ultrasound. That's just the basics of the physics of how the devices work. I also would like to see some more outcome studies with the NICOM device. But boy, I tell you, I would love for it to work perfectly because it is so easy to use. From a science point of view, I'm just a little hesitant about saying that.
Perfect. All right. I think we have time for one more, and kind of want to end the call on this. Does the benefit of ultrasound outweigh the cost of the purchase of ultrasound?
I would say absolutely. Now, I'm not the one that always will be buying it, but personally what I did is I bought my own handheld ultrasound because I knew I didn't want to fight the administration for it. So that's how much I believe it's helpful, is the handheld ultrasound lets me do so much so fast that I can't do with any other technique. And then the flow ultrasound just makes it easier for me to judge how much fluid to give in that. But again, this presentation, we really only talked about a little bit of what the ultrasound can do. And really for looking at the septic patient, it has so many more applications. So its cost benefit to me is crystal clear.
Perfect. And once again, Tom, I want to say thank you for your informative lecture. I know that I have certainly learned a lot today, and I hope that our viewers have as well. So with that being said, again, we would like to thank you for spending time with us today and learning about sepsis and septic shock and how ultrasound may aid in the assessment. Once again, in case you'd like to assess today's presentation in the future, please note that in a few days, an email will be delivered to you with a link to the recording of today's webinar. Thank you again for your time and attention. Please watch for more communications on future webinars from GE on the topic of medical shock. Thank you, and everyone have a great day.
Thanks, everybody.